Good afternoon, everybody.
Good afternoon, Ms. Smith.
My name is Vicki Smith. We're going to be reviewing the Atrium Oasis dry section and water seal collection chamber today for chest tubes, and we'll be overviewing the nursing implications for the the implications for chest tube maintenance. For a quick review, let me remind you that the closed chest drainage system is used to restore negative pressure by evacuating air, fluids, or blood from the intrapleural or mediastinal space. That will help reinflate the lung. For demonstration purposes, we'll be reviewing the Oasis Atrium water seal. This is what we use in this facility. Traditional suction units have 3 chambers. We've got suction control chamber, the water seal, and the collection chamber. They can be placed, as I've said, to water seal or just to dry suction, and the amount of suction is determined by the amount set in the suction control chamber, usually a negative 20 millimeters of H2O, or centimeters of H2O. Before a chest tube is inserted by the provider, you as the nurse have several several things that you need to ensure that are completed. First, you need to explain the procedure to your patient, and also what the drainage system is. It can be kind of scary to anybody that's not used to seeing that at the bedside. You want to teach the interventions for expanding the pulmonary function, the pulmonary toilet, turn, cough, deep breathe, ambulate, use the incentive spirometer, so you want to have that at the bedside. You also want to review the pain management plan with the patient. Also, any signs and symptoms of respiratory distress. If they feel impending doom or they feel a heaviness in the chest, they need to know to report this to you. Things to look for. In patients who are breathing spontaneously, there's going to be a rise and fall of the water chamber here. This is called tidling. It's going to fall when they exhale, and it's going to rise when they inhale, which is showing that the negative pressure in the lung is expanding. The absence of that tidling means that there's an occlusion in the system, so you need to notify the provider. The collection system must always stay below the level of insertion without any dependent loops. So by dependent loops, it's if the patient's lying in the bed and you've got excess tubing and it's looped like this, it's going to keep the drainage right here instead of going into the collection system for proper measurement. Semi-Fowler's position is most beneficial for drainage. If the patient's supine, though, you need to put this at the foot of the bed and make sure that the tubing is run parallel and kept at the side of the patient, not just draped down across the bed. Nursing assessment of the water seal chamber needs to happen. If I have a patient with a chest tube, I'm in there probably every hour just taking a look at it at the minimum. You want to make sure that this water seal is a one-way valve. You do want to make sure that there's tidling. As I said, the rise and fall of the water in the chamber. When the patient exhales and is breathing spontaneously, you will see some water bubbles here, but if they're constant, it signifies that there is an air leak. So what do you do if you suspect an air leak? Does anybody know what's the first thing you would do? Air leak. Ms. Hanson?
Follow the tubing from the patient to the device to make sure your connections are correct.
Very good, absolutely. This is one of the few times that you can clamp the tubing. You want to start at the chest wall. You'll clamp padded padded hemostats only at the bedside. You'll clamp at the insertion site. If the bubbling stops here, it signifies there is a leak in the lung or at the insertion site. At that point, you will stop and you will notify the provider. If the bubbling continues, the leak is between the clamp and the chamber. So you will, again, move the hemostat down, clamp. If it stops, then you know it's between the insertion point and that level. You'll go down until you finally sequentially clamp off until the bubbling stops. Once you do all this, just make sure you unclamp. I mean, it's just very quickly checking that tubing. If it is in the collection system, you will just change out the whole system. Again, if it's at the insertion site, you notify the provider. If you need a drainage sample, does anybody remember from our previous review how you would collect that? Miss Sutton?
You actually have a port on your drainage tube that you can draw out of, or you have the resealable tubing that you can stick.
Okay, she's correct. There is a collection, a needleless collection system here with a backflow preventer. So when you do draw from here, it's pulling from the tubing, not from the chamber. And as she said, this is a self-closing system. I really don't like using this system, but if you do use it from the dependent looping, instead of up here, what you would do is form a dependent loop, get until you have enough collection sample. You'll clean the tubing with alcohol. You're going to get a needle and a syringe no larger than a 20 gauge, otherwise it could damage the tubing and it may not close up. You're going to insert very shallow, and again, because the needles are so long, you can see it can be difficult, but you will insert and you can withdraw. Once you pull the needle out, it will self-close for you. So the collection chamber up here, like I said, it's needleless, so you'll just withdraw like this. So I'm really not sure why you have both options that you do. Does anybody know that answer from the instructor? No? Okay. Let's see. So you always want to label the specimen in the presence of the patient before you leave the room and transport it to the lab. Usually you want to get that down there pretty fast. The water seal chamber, when you have the initial setup, and I do have a video to share with y'all, if this at any time gets overfilled, you fill it up here, there's a grommet in the back that you would use a 20 gauge needle for, inject out, and you can withdraw your fluids until you get to the level needed. Did you have a question?
No, I didn't know that.
Oh, really? Yeah, it's the same thing. It's self-sealing, and you can just withdraw the fluid just so you stay at that 0 line or more. All right. Too much water. Of course, too much water can really have an impact on the patient's breathing because of the way the suction's set up. If the water chamber is over full, it causes more suction. So it really doesn't reflect appropriately. You can hang these at the bedside, either with the hangers that they have, and they made these, they appear to be flimsy, but they're pretty strong, and they're made like this because they can hang on any bed. With all the new beds and the bed frames, they've changed things up a little bit. And of course, you always have the bottom that folds out to set up right. If this gets kicked over and some of your drainage goes into the other chambers, I've had some staff that would actually try to measure each chamber and add them up. But what you can do is just tip this until you run the fluids back over into the one chamber to get an accurate measurement. The sides of the measurement on the white area here, They're coarse so that you can use a pen or a marker on them. At the beginning and end of every shift, you want to mark beginning and end, or verify it with your off-going shift, and make sure it's recorded in eyes and notes. If the tube is dislodged at the site of insertion, you want to take a sterile gauze and tape it 3 sides only. Notify the provider. You don't want to tape it off on 4 sides because it can cause a tension pneumothorax, and you do not use the petroleum gauze anymore. They've shown that the petroleum gauze actually breaks down the suture tensile strength. So no more petroleum gauze, and it also leads to increased risk of infection. If the drainage system comes apart, if this comes off the chest tube itself, clean it, antiseptic wipe, and hook it back up. If it's damaged, you can change out the whole system. Don't clamp the tube though until you do that. What you want to do is take the end of the chest tube and put it in a cup of sterile water just to keep that suction seal going. If you don't and it's just open, it can introduce air from the outside. All right, reportable conditions to the provider. If you go into your patient's room and they're in obvious respiratory distress and they're grunting, they're restless, tachypneic, definitely want to talk to the provider then. Decreased or absent breath sounds, tracheal shift from the midline, definitely show hemothorax, feeling of doom, muffled bark sounds, things like that, you definitely want to notify. Insertion site if there's excessive bleeding, swelling, edema, erythema, excuse me. If there's a change in collection amount, color, clarity, you want to let them know. Cessation of titling, again, that would show an occlusion of the system. So when you go to document, you'll be assisting the provider or the physician with insertion of the tube. You want to document the amount of section, the drainage that was initially drawn off, the presence or absence of an air leak. This is also not just at the time of insertion, but for follow-up. Site assessment, pulmonary toilet, incidence barometer, deep, cough turn, deep breathe, ambulation, the patient's response, comfort assessment, and education provided to the family and the patient. And that's all that I have as far as just the overview. I do have some questions and stuff we'll go over, but did y'all have any questions for me? Okay. So we'll have a little fun quiz time now. All right. These are NCLEX type questions that you can look forward to have on your NCLEX exam. Okay, so I'll read them, and whoever gets the right answer gets candy. All right. Let's see. Okay. So raise your hand so y'all don't get in a fight over candy. I know how nurses are. Okay, a nurse is caring for a patient with a mediastinal chest tube. 1 hour after walking the patient around the unit, the nurse notices an increase in the amount of drainage from the patient's chest tube. Which statement is true regarding this finding? A, an increase in drainage after ambulation is normal but should be monitored closely. B, the patient should have a chest x-ray because tamponade may be developing. C, a decrease in the amount of drainage is normal and the practitioner should be notified. Or D, an increase in serous drainage could indicate a ruptured suture line. Okay, go ahead. A, that's correct. Very good. So you get your choice.
Thank you.
All right. sorry, give me 1 second. I don't know how to pause that, or I would right now, so, doctor. Okay. I thought I had some more information. Okay. Number 2, when transporting a patient with a mediastinal tube, which action is the most appropriate? A, ensure that the portable section is available during transport. B, ensure that the tubing is clamped before removing it from the suction source. C, ensure that the chest drainage system is below the thoracic level. Or D, ensure that titling occurs throughout transport. Ms. Sherry, would you like to answer that one?
C.
Correct. Ensure that chest drainage system is below the thoracic level. See, we didn't think I would take those. A patient who has been involved in a motor vehicle crash has a pleural chest tube. The water seal chamber is bubbling from right to left. What does this finding indicate? Patient may have a pneumothorax. The system needs to be replaced. There's an external air leak, or the centimeter H2O section should be reduced. Ms. Sutton, would you like to answer that one?
Can you reread the question?
Certainly. A patient who has been involved in a motor vehicle crash has a pleural chest tube. The water seal chamber is bubbling from right to left. What does this finding indicate?
An air leak?
Pneumothorax. External air leak. It would be bubbling consistently, but with the motor vehicle crash, a lot of times they are putting in a chest tube to relieve a pneumothorax, and you'll see the air initially. And actually, we didn't really cover that. I think that was in your assigned reading though last night.
I'm sorry.
But I'll still give you it. Okay.
I'll give you the one again.
When managing a chest tube drainage system, Ms. Hanson, which action should the nurse take? Ensure that the system remains at the head of the bed if the patient is in the prone position. Ensure that the chest tube is not stripped. Clamp the tube if the drainage collection system becomes damaged. Or D, ensure that the tubing is looped off the side of the bed to prevent kinking.
Let's see.
B, ensure that the chest tube is not stripped.
Oh,
So you
okay.
never want to
Well,
strip
that's
the
what I thought
chest
C
tube.
was, I'm sorry.
Oh, okay, yeah, no, that was the clamp, so I know you know.
We'll give you failures over here.
We'll give you the York peppermint. Okay, you did fine
You have to go
though.
back to school.
It's kind of hard to,
When you're not looking at the answers, gotta remember what order they.
right, yeah. So a nurse notices that the chest tube drainage looks milky. The provider requests a sample of the fluid to be sent to the lab. What should the nurse do? Ensure that the provider obtains the sample when the tube is placed. Insert an 18 gauge into the dependent loop after it's cleaned. Insert a 20 gauge into the grommet on the system, which is on the back. Or insert a 20 into the dependent loop after it's cleaned.
D.
Miss that, very good, y'all can split. Okay. All right, I have a video, it's kind of an overview of what we've already discussed. So I will move the display board, which is also up for your review, if you care to look at that after the video. Okay, I'm gonna cut this backlight. Oh yeah, thanks. Forgot I had this right here.
All patient tubes and suction connections should be routinely checked to ensure proper leak-proof operation and chest tube patency. Like all Atrium models, the Oasis 3600 single drain collection chamber incorporates a large writing surface with big, bold numbers and easy-to-read fluid level graduation, depending upon your hospital sampling technique. Samples of drainage fluid can be taken directly from the patient tube by forming a temporary dependent loop and inserting a 20 gauge or smaller needle with syringe at a shallow angle. On selected models,
That's
samples
that
can be
larger.
taken directly from the needleless
20 gauge
Luralock
or
sampling
larger.
port located on the patient tube
Yeah, she
connector.
said smaller.
A water seal is a simple one-way valve which allows air to exit the chest and prevents air from returning to the patient under normal conditions. It's also a very useful diagnostic tool, as it can show even the smallest trends of an air leak, as well as changes in intrathoracic pressure. Assessing patient air leaks is easy with Atrium's blue tint water and graduated air leak monitoring. Continuous bubbling observed in the water seal will confirm a persistent air leak in either the patient's thoracic cavity or possible tube connections.
Y'all see how it goes from 1 to 5?
Float ball
It'll stick to
oscillation
5.
will confirm the presence of an intermittent air leak, and no bubbling with minimal float ball oscillation
right
at the
to
bottom of the
left.
water seal indicates that no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. The Oasis Graduated Air Leak Monitor allows visual detection of air leaks from a low volume of 1 to a larger air leak volume of 5. Air bubbles passing through the Graduated Air Leak Monitor help the clinician assess air leak patterns and patient air leak trends. Changes in intrathoracic pressure can be determined by observing the level of the blue tint water and float ball in the calibrated water seal column. Atrium's blue tint water and float ball make changes in patient pressure easy to monitor, even in low light conditions or from a distance. When monitoring a patient's chest drainage system, it's important to periodically check the water seal's operation and fluid level. If the water seal is either underfilled or overfilled, it should be adjusted accordingly to the prescribed maximum 2 centimeter level. Using a 20 gauge needle with syringe, adjust the water level via the grommet located on the back of the water seal chamber. In the event of an accidental knockover, upright the drain immediately and check all fluid levels. If required, the water seal level may be adjusted back to its original 2 centimeter level as previously demonstrated. If a knockover does occur, fluid drainage could potentially spill from one collection column to another. If this occurs, gently tip the drain to the right to return fluid back to the correct column, and then upright the drain. Most healthcare facilities routinely use suction for their patients, as it helps improve the rate and flow of fluid drainage from the patient and out through the thoracic catheters. The patient tube slide clamp must remain open at all times during system operation. It's recommended to position the patient tube clamp next to the inline connector for setup convenience and routine visual check. The patient tube clamp can be removed if desired. Handling and disposal of a discarded chest drain and its contents should be in accordance with all applicable regulations and approved hospital infection control standards.
A lot of times I've seen patients with this being within hand's reach, they'll play with it and they can actually inadvertently clamp this off and not realize it. So I have found I'll either pull it down here or I'll take it off totally. Do I have any questions?
No, ma'am.
Did y'all learn anything? Did you?
Yeah.
Good, awesome.
Thank
Do
Good.
you sedate your patients when you put these in?
Oh, absolutely. It is a painful procedure. It's not pleasant. And the physician will use the lidocaine or whatever other topical analgesic at the site. So definitely advocate for your patient for some pain medication. Yes, definitely. Okay, well, thank y'all very much.
Thank you.